autosclerosis. So just to start, in terms of definitions, our prescribed textbook, Scott Brown, defines autosclerosis as a localized hereditary disorder of bone metabolism of the otic capsule endochondral bone that is characterized by disordered resorption and deposition of bone. Clinical autosclerosis specifically refers to lesions that manifest in a conductive hearing loss and most commonly are due to fixation of the stapes footplate. Cochlear autosclerosis, also known as retrofenestral autosclerosis, is much rarer and is present in 10% of cases. Specifically, it is due to described lesions involving the cochlear endosteum manifesting in a sensory neural hearing loss or a mixed hearing loss. Histological autosclerosis refers to the histopathological presence of lesions that may be symptomatic or asymptomatic, and it is usually used to describe the overall incidence of disease, often in temporal bone studies. In terms of the pathophysiology, very basically, as we said, the disease is isolated to the otic capsule or bony labyrinth, which is the osseous layer of the temporal bone which surrounds the membranous labyrinth of the utricle, saccule, vestibule, semicircular canals, and cochlea. This otic capsule is unique in its relative stability compared to other skeletal sites, exhibiting very little bony remodeling outside of autosclerosis. Also, secondly, in that autosclerosis has not been reported outside of the temporal bone or in other mammals. An otosclerotic lesion is a dynamic, evolving lesion consisting of areas of bone resorption by osteoclasts and new bone formation by osteoblasts, accompanied by areas of vascular proliferation in a connective tissue stroma. These lesions can be described in two different phases, which can coexist within the same lesion, including active phases, also known as otospongiosis, characterized microscopically by an increased vascularity and bony turnover within the lesion, and an inactive or sclerotic phase consisting of dense mineralized bone. I don't want to focus too much on the etiology, but essentially multiple theories have been postulated, none of which can completely explain the disease in isolation. There's a definite genetic component with an autosomal dominant inheritance with variable expression and penetrance of up to 40%, with multiple different genes implicated. The remaining theories have limited supporting evidence, but include the post-viral theory, which suggests that it is related to the measles virus. This is based on measles RNA isolated from the perilymph and frozen footplate specimens in patients with autosclerosis, as well as a decrease in incidence in communities following measles vaccination programs. An autoimmune theory also exists, which postulates that antibodies against type 2 collagen fibers are responsible. Against this theory is that these antibodies have been found in normal individuals outside of autosclerosis, and also that type 2 collagen fibers are not unique to the otic capsule, and in affected patients, they don't affect collagen fibers outside of the temporal bone. Other theories include an abnormal genetically determined cytokine response, a hormonal theory based on worsening disease with pregnancy, and an older post-traumatic theory. Epidemiologically, there's an identifiable family member in up to 40 to 50% of cases, with the remainder of cases being sporadic. The male to female ratio differs from study to study, but seems to be 2-to-1 in favor of females. Autosclerotic foci typically begin in late teens to early adulthood, with the incidence of clinical autosclerosis increasing with age. 70 to 90% of cases are bilateral, and it tends to be radiologically symmetrical. However, patients are not commonly simultaneously symptomatic in both ears. There is an overall reported incidence of 10% of histological cases in Caucasians, with a 1 to 2% overall incidence of clinical autosclerosis in Caucasians. The disease is significantly rarer amongst Asians and even rarer in Black races, with earlier studies even questioning its existence at all in Africans. There's hardly any literature regarding otosclerosis in South Africa or Africa, and therefore the incidence is largely unknown. In a very old study conducted in 1944 in Black African Americans in the US, an incidence of 0.9% of histological otosclerosis was demonstrated in a collection of 576 temporal bones. In the largest case series I could find, conducted by Professor Chifalaro, 31 Black South African patients were identified with clinical autosclerosis. These patients were recruited from different provinces throughout South Africa. The ethnic breakdown is reflected in the pie chart with 77% Sotho representation, 19% Xhosa, and a 3% Zulu representation. So this definitely seems to be an area for future research within Africa, and I invite anyone from other provinces or countries to comment using the chat function regarding their local incidence of otosclerosis. In terms of the clinical presentation, patients typically complain of gradual onset, slowly progressive hearing loss over a number of years. Typically non-pulsatile tinnitus, but also pulsatile tinnitus is described in active phase. Paracusis of Willis is the paradoxical improvement in hearing in noisy environments, a positive family history, and it's also important to inquire in the history regarding other causes for conductive hearing loss, such as a history of trauma, which may suggest ossicular injury, or background of chronic or acute otitis media, which may suggest healing with Tympanos sclerosis. 50% of females give a history of worsening during pregnancy, and 10 to 30% exhibit non-specific variable vestibular symptoms. Clinically, these patients usually have a relatively unremarkable ENT exam. Tuning forks are typically in keeping with a conductive loss. A pneumatic otoscopy is typically normal with a mobile tympanic membrane. Rarely is the Schwartz sign or flamingo flush seen, which is described as a red blush due to increased mucosal vascularity over the promontory, which may indicate that the disease is in an active otospongiotic phase. It's further important to realize that due to the relatively high incidence of otosclerosis in the general population, it can occur in conjunction with other middle ear disease, and therefore can also occur when the tympanic membrane is abnormal, such as in conjunction with chronic otitis media or perforation. And it's therefore important to emphasize to always keep it in the back of your mind, and especially to examine the middle ear for features of occult otosclerosis whenever exploring the middle ear for other reasons. Audiologically, these patients typically present with normal type A or type AS TIMPs with reduced peak compliance. And in terms of acoustic reflexes, classically the reflexes are absent due to the combination of hearing loss with physical fixation of the footplate. However, they may be normal in early stages of disease. Acoustic reflexes are paramount in narrowing down your differentials for a conductive hearing loss with an intact tympanic membrane. Specifically, where acoustic reflexes are uncommonly present, one should consider third window lesions like a semicircular canal dehiscence or even an enlarged vestibular aqueduct. Other differential diagnoses and their associated acoustic reflexes are indicated in the illustrated table. Pure tone audiometry is characterized typically by conductive hearing loss, which is most marked in the lower frequencies, as illustrated in the audiogram below, where a constant pancochlear airbone gap is atypical of otosclerosis and may indicate the need for further investigation. Carhartt's notch is classically described, which is defined by an elevation of bone conduction thresholds by 15 decibels or more at 2000 hertz. It occurs secondary to the Carhartt effect, which describes that bone conduction is achieved by three mechanisms. Firstly, as indicated in pathway A, via direct vibration of the skull with transmission directly to the cochlea. Secondly, by pathway B, via vibrations within the ossicular chain. And thirdly, by pathway C, via vibrations of the external auditory canal, transmitted via the tympanic membrane to the ossicles and to the oval window. In autosclerosis, as well as in other middle ear pathology, transmission via the ossicular chain and external auditory canal is lost, which results in the pathognomonic elevation in bone conduction thresholds audiologically. It is said to occur at 2000 Hz specifically because that is the resonant frequency of the stapes and ossicles and is where the effect is maximal. Carhartt's notch can further be used to estimate the degree of cochlear otosclerosis, where an increase in bone conduction thresholds beyond 15 decibels is suggestive. Logically, with progression of cochlear sclerosis, a more mixed hearing loss is found audiologically, and this is important as it can be used in preoperative patient counseling and management of expectations with Stape surgery. The notch was initially described in Autosclerosis, however, it has subsequently been found to occur in all ears that have a conductive impairment. So what happens audiologically following Stapedectomy or successful Stape surgery? Well, hopefully you will reestablish all three routes of bone conduction. And if the new air conduction thresholds are superimposed on the old bone conduction thresholds, you have this overclosure phenomenon occurring. With the reestablished three routes of bone conduction, if bone conduction thresholds are now repeated post-operatively, they will show resolution of this overclosure phenomenon. So in terms of audiology, how does one define the audiological eligibility for stapedectomy? This is a controversial topic. Historically, the consensus minimum air gap of 20 decibels has been used. Some surgeons still rely on the C2 512 tuning fork as a reliable indicator of a 25 decibel or more loss. There are many proponents who will now consider operating on smaller air bone gaps between 10 to 20 decibels, where the opinion is that if the air conduction thresholds can be brought up to the preoperative bone conduction thresholds, the patients may appreciate the improvement in their hearing, especially in cases of bilateral disease. More recently, these boundaries have been further pushed by some Stape surgeons to an air bone gap of up to 10 decibels, where proponents claim there's a potential for a greater than 10 decibel improvement due to the Carhartt effect. The concern at air bone gaps this small is that the air bone gap may rather be due to artifacts of audiometric testing. Therefore, should such a small air bone gap be considered, it should be reinforced by multiple audiograms confirming the air bone gap, with tuning forks in keeping with the conductive loss, and again, absent stapedial reflexes. The other obvious concern at small air bone gaps is that the smaller the air bone gap, the less likely the patient is to appreciate the subjective audiological gain. In a study by Lippi and colleagues, the authors looked retrospectively at 136 stapedectomies with preoperative air bone gaps of 10 decibels or less. The audiological results were impressive, with an average of 17 decibel improvement post-operatively in pure tone audiometry, and 89% had a pure tone average of 0 decibels or better. However, word recognition scores remained unchanged at 96%. Unfortunately, my other concern regarding this paper and a few similar papers is that there are no patient-reported outcomes to confirm a subjective improvement in patients' hearing to justify the surgery. Also, to bear in mind, the surgeon in the above paper was an extremely experienced Stape surgeon and was part of a greater series in excess of 3,000 cases, in which he consistently achieves an air bone gap of less than 10 decibels. Having said this, it is paramount that Stape surgeons, especially when embarking on controversial air bone gaps, counsel patients properly and manage their expectations, and more importantly, audit their own outcomes. So in terms of CT scanning, the first question is who to scan. Now with the increased availability of CT scanning and the increase in defensive medicine, many centers routinely CT scan patients prior to all Stape surgery. The sensitivity of high resolution CT scanning varies from 70 to 90%, and there seems to be no significant difference between cone beam and conventional high resolution CT for otosclerosis. Our institution still practices the philosophy that autosclerosis is a clinical diagnosis based on history and audiometric findings and confirmed at the time of surgery. We do not routinely perform CT scans, reserving CT scans for cases of diagnostic dilemma or in atypical features where considering revision surgery or cochlear implantation. And I invite any people from other institutions to comment on the chat function regarding their use of CT scan and otosclerosis. Examples of cases in which a CT scan may be recommended include a conductive hearing loss but absent Carhartt's notch, an atypical pancochlear airbone gap in cases of mixed hearing loss, in pediatric cases, unilateral disease, in cases with associated vertigo or features suggestive of a third window, and with a previous history of acute otitis media, chronic otitis media, or even trauma. Having mentioned these in a resource constraint or even abundant setting, an exploratory tympanotomy with microscopic evaluation and palpation of the middle ear is perfectly acceptable in cases of diagnostic dilemma without a CT scan prior. So next, in terms of scanning, what is it important to look out for? So it's obviously important to look for features of otosclerosis to support your diagnosis. And on CT scan, autosclerosis is really a bit of a misnomer, with most lesions appearing isodense or hypodense compared to normal temporal bone. Rarely are hyperdense sclerotic foci visualized in advanced stages of disease. The earliest and most common radiological feature is radiolucent lesions found at the fissula antifenestrum, which literally translates to the fissure anterior to the oval window. These are typically best visualized on axial slices, and this is nicely illustrated in this scan, which shows normal to perhaps minimal plaque in the right ear, with more obvious large anterior oval window plaques in the left. As the disease progresses to become retrofenestral involving the cochlear otic capsule, you may start to see areas of demineralization throughout the bony labyrinth, which can be appreciated as the so-called halo sign or double ring sign. As I said, the disease exists typically on a continuum, which has led to the development of multiple different radiological grading systems, such as this one published by Marshall in 2015. So next, in what else to look out for, it's important to look for other causes which may account for the patient's symptoms or even rarely a dual pathology, such as a third window lesion, more specifically a superior semicircular canal dehiscence, which is best viewed in the partial coronal view in the perpendicular plane of the superior semicircular canal, with this CT scan illustrating the classic dehiscence of the arcuate eminence. It's important to look for features of tympanosclerosis, features of an enlarged vestibular aqueduct, congenital ossicular anomalies typically occurring in younger age groups, which often are subtle, like an isolated incudostapedial disarticulation or absence, a facial neuroma, and I've also included evidence of an old temporal bone fracture or traumatic ossicular dislocation or fracture, which is a common local presentation where background of history of trauma is not always reported. Just to also mention that there's a differential for extensive demineralization of the otic capsule, which can be easily confused with retrofenestral otosclerosis. A perhaps generous differential includes osteogenesis imperfecta, Paget's disease, some neoplasms, otosyphilis, osteoradionecrosis, sometimes cholesteatoma, fibrous dysplasia, as well as cholesterol granulomas. And lastly, it's important prior to stapedectomy, if you have decided to perform a CT scan, to look for the following features which may negate or alter your surgery, such as oval window or round window obliteration, cochlear otosclerosis, additional fixation of the malleus and incus, features which suggest there may be a risk of a CSF gusher, and the position and possible dehiscence of the facial nerve, persistent stapedial artery, and evidence of previous surgery or trauma. Moving on to the management, there are essentially three arms of management. There's medical management and observation, hearing aids, and surgery. Prior to allowing patients to make any informed decisions regarding their management, it is paramount to give them a rough idea of the natural history and the anticipated course of their disease. The general estimated conduction cells will deteriorate by 2 decibels per year, and bone conduction per year. So you're looking at about 10 decibels. Nick, can you hear me again?
Yeah, we're back on. If everyone can just mute their microphones, please, when you join. Thanks. Continue, Matt.
So just following on, the need for a hearing aid post-stapedectomy is also roughly quoted as 30% in 30 years. And the rate of revision surgery following primary stapedectomy is approximately 20%. In terms of medical therapy, what is the role of fluoride? Well, theoretically, the hypothetical benefit is that it may convert active disease into more stable inactive disease and reduce the progression of hearing loss. Fluoride may be administered in 2 ways: through universal fluoride supplementation of drinking water. However, unfortunately, studies out of communities like Finland have shown no reduction in clinical autosclerosis. The second method is through the prescription of fluoride tablets, where one small randomized controlled trial showed a possible decrease in the rate of sensory neural hearing loss. Unfortunately, it's recommended at very high doses over a period of at least 2 years, and as a result, side effects such as GIT upset, anemia, synovitis, and plantar fasciitis are common. And multiple studies have also looked at the role of bisphosphonates, with 2 smaller studies showing possible benefit with 3rd-generation bisphosphonates like zoledronate. Conventional hearing aids are an effective and often forgotten alternative management to Stapes surgery. The option of a hearing aid should at very least be discussed with the patient, with many institutions giving all patients a mandatory trial of a hearing aid as a form of a proper informed consent prior to consideration for surgery. They're obviously a much lower risk alternative to Stapes surgery and obviously avoid an anesthetic in the elderly or infirm. There are unfortunately no randomized controlled trials in the literature directly comparing Stapes surgery to hearing aids. One recent study I found, which is extremely relevant in our context, is this study conducted by Gillard and colleagues published this year, which assesses the cost effectiveness of stapedectomy versus hearing aids in otosclerosis. In this study, they essentially produced a model which reflected the anticipated average lifetime cost to a 30-year-old with otosclerosis, managed either with primary surgery and possible later revision surgery, compared to that same patient managed with hearing aids. Following complex statistical analysis, they inferred that the average lifetime cost to a patient with stapedectomy is approximately $1,900 US versus $1,600 with a hearing aid. The stapedectomy, despite being more expensive, had benefit in terms of quality adjusted life years compared to the hearing aids. One limitation to the study is that it did not infer the cost accrued by the patient versus the cost accrued to the medical aid. A similar study would be interesting in our developing world context. Bone-anchored hearing aids have been proposed as an alternative method of managing otosclerosis in a limited number of situations. Selection criteria are similar to those typically used in Carhartt programs for other conditions, with average bone conduction thresholds of 40 to 60 decibels and speech discrimination thresholds of 60 decibels or better depending on the device. The main benefits over stapedectomy are a lower risk of complications, particularly a dead ear or post-operative tinnitus or vertigo, and they are therefore a potentially safer alternative in an only hearing ear. There may be a more reliable alternative at closing the ear-bone gap for a relatively inexperienced Stapes surgeon. And Carhartt, as we know, is reversible and does not preclude the subsequent Stapes surgery. It is also a good option where Stapes surgery is contraindicated, such as in dual chronic otitis media or eustachian tube dysfunction with associated otosclerosis. The non-invasive Baha soft band or the adhesive adhere offers a potential for a trial period. Some disadvantages compared to stapedectomy include inferior cosmetic outcomes, and I would predict that the long-term cost of a Baha would be more. When compared to conventional hearing aids, the following study showed that the Baha outperformed conventional hearing aids in all spheres, including hearing and noise, cosmesis, comfort, and patient-reported preference, with audiologically equivalent or better outcomes compared to hearing aids in otosclerosis. So moving on to Stapes surgery, the aim of surgery is to achieve maximum hearing gain with minimal damage to the membranous labyrinth. It may be considered in 3 different categories depending on the cochlear reserve of the patient. Firstly, to achieve normal hearing in patients with normal cochlear reserve, to achieve serviceable hearing in patients with minimal reduction in cochlear reserve, and possibly to eliminate the need for a hearing aid. And finally, to improve hearing aid satisfaction. Candidacy for Stapes surgery, like many other ENT surgeries, can be broken down into 3 spheres, including patient factors, institutional factors, and disease factors. If we look at patient factors, the first factor is the patient's general fitness for anesthesia. This has become less of a concern with more and more surgeons performing Stapes surgery under local anesthetic. In the following systematic review of 3 studies, including a total of 417 procedures, comparing stapedectomy under local versus general anesthetic, there was found to be no statistical difference in post-operative air bone gaps, the rate of sensory neural hearing loss, or post-operative vertigo, with one study even suggesting an increased risk of dead ear with general anesthetic. Local anesthetic has other benefits, obviously avoiding the risks associated with general anesthetic. It allows for real-time patient-reported auditory feedback, and obviously cost savings. Obviously, not all patients are appropriate for procedures under local, such as children. And then, like any surgery, there is the patient's preference and expectations to take into account. So in terms of age, there's no real upper limit in terms of stapedectomy, obviously being cognizant of the other factors we'll subsequently discuss. However, there is controversy regarding stapedectomy in the pediatric population. Pediatric or juvenile otosclerosis is rare. Your differential in children would include congenital ossicular anomalies, OME, congenital cholesteatoma, or an enlarged vestibular aqueduct syndrome. The main concern is to exclude congenital Stapes fixation, often associated with an X-linked Gusher syndrome. In this condition, the Stapes foot plate is congenitally fused with the annular ligament, and this condition is often associated with other middle and inner ear conditions. It may be difficult to distinguish congenital Stapes fixation from juvenile otosclerosis. However, clues include that in children with Stapes fixation, they typically have a pantonal conductive loss from birth, which typically does not progress, whereas juvenile otosclerosis typically progresses with age, with typical audiological features and the absence of other associated malformations on CT scan. This is why a CT scan is required in all pediatric patients with suspected otosclerosis. The following systematic review highlights the importance of making the distinction between the 2 conditions, where the success rate of stapedectomy in juvenile otosclerosis is 80% and only 54% in congenital Stapes fixation, which is important in patient counseling and possibly considering alternatives to stapedectomy in cases of congenital Stapes fixation. In addition, juvenile otosclerosis is associated with an increased incidence of obliterative otosclerosis in approximately 26 to 41% of cases, which is important to be cognizant of. Regarding the relevance of occupation and leisure activities, this is relevant in 2 spheres. Firstly, with regards to their dependency on their hearing, specifically, are they working professions such as the music industry where they are extremely reliant on the quality of their hearing? And the second aspect is a risk of barotrauma, such as in pilots or divers at high risk for barotrauma and its complications. Historically, we all know that military pilots were grounded post-Stapedectomy, which is unfortunately no longer done. However, there seems to be no consensus as to when one can safely return to these activities after surgery. The suggested time delay is to allow for the connective tissue seal to mature, and in one survey conducted amongst 419 otologists in the UK, 12% placed no restriction on post-operative flying, 20% 2 days, and 60% suggested 2 weeks or more. In terms of scuba diving, 35% suggested no diving for 1 to 6 months, and 50% advocated for a permanent restriction. In the presence of Meniere's disease, there's a theoretical concern that with underlying endolymphatic hydrops, patients are at risk of a perilymphatic fistula and Gush's syndromes. However, clinical studies have shown no difference in hearing outcomes post-surgery when compared to patients without Meniere's disease. Then to look at the second arm, there are disease factors which need to be taken into account when considering whether or not to offer a patient surgery. Audiological candidacy, as we have already discussed, is important, and I think most would agree a 20 decibel airborne gap or more is sensible. In unilateral autosclerosis, the concerns are firstly that the conductive loss may in fact be due to something else, as unilateral disease is uncommon in autosclerosis. And secondly, we know that a patient's disability in terms of subjective hearing is mainly determined by the hearing threshold in the better ear. So only if one can achieve near symmetrical hearing will the patient benefit from the benefits of binaural hearing. In terms of second side surgery, most would perform second side surgery, presuming the initial contralateral surgery has not resulted in a dead ear, and again, giving the patient the potential benefits of binaural hearing. Operating in the active phase of otospongiosum, which may be clinically indicated by a Schwartz sign on otoscopy, is rare and mostly anecdotal, with some surgeons postponing surgery until the Schwartz sign is no longer present. Active or external middle ear infection or a mastoid cavity is considered in our unit an absolute contraindication. We consider pregnancy an absolute contraindication, and one may consider postponement until family planning is completed. Eustachian tube dysfunction and an only hearing ear are also considered contraindications, and the latter two anomalies I'll later discuss. The third element is institutional factors, which are dependent on the resources available, the skills of the local surgeons, and the cost of the interventions. The next question is one that always is an interesting debate. At what point is an ENT surgeon considered otologically proficient enough to perform Stapes surgery? And once having started performing Stapes surgery, after how many cases are you considered proficient? This is obviously a challenging question to answer. And as our professor always says, you can play a lot of golf, but that's not necessarily going to turn you into Tiger Woods. It's well documented that the number of Stapes surgeries has decreased over the last 20 years through addressing a backlog of cases, combined with an improvement in the quality of hearing aids, and possibly through an increased fluoride supplementation of the drinking water. The decrease in case numbers is further compounded by the increase in ENT surgeons, meaning that there are fewer cases for training purposes and fewer numbers to maintain consistency on. This is possibly made worse by the global increase in medico-legal litigation, which is always in the back of one's mind. Routinely in the 70s to 90s, stapedectomies were regularly being performed by registrar trainees, while now, today, many ENT surgeons are performing their first cases as consultants or not even. However, having said this, there are multiple studies illustrating poorer outcomes in Stapes surgery performed by trainees versus experienced otologists. I don't think there's any golden number or perfect test for proficiency. The general consensus from master otologists is that the individual trainee should illustrate the necessary dexterity and other middle ear work, and the temperament of an otologist as judged by a supervisor prior to starting Stapes surgery. It's also agreed that there's a natural progression in terms of the learning curve in otological surgery, starting with laryngoplasty and progressing to ossiculoplasty, cholesteatoma surgery, and Stapes surgery at the end of the spectrum. A few studies have attempted to determine the point at which competency is reached. The most recent I could find was this study out of the UK, the learning curve in Stapes surgery and its implications to training. This interesting study is a retrospective review of the outcomes of the first 100 primary stapedectomy operations performed by 2 different ENT surgeons. The success rates with the increase in surgical experience of both surgeons were plotted on the graphs and represented their individual learning curves, with the average post-operative air bone gap on the y-axis and the case numbers on the x-axis. If you look at these graphs, there's no clear-cut endpoint in which both surgeons' curves reach a definitive kind of point. However, there seems to be a so-called landmark point around 60 to 80 cases at which point consistency in results is achieved. Also of note is that each surgeon has 1 dead ear in each of their first 15 cases. In the interest of time, in terms of surgical technique, I'm not going to go through each step involved in stapedectomy, but would highly recommend the audience to read this chapter authored by Professor Linda and Dr. Harris in the UCT-Africa open access online resource, which is the best surgical guide I have read and can be found at the above URL. Historically, a big debate exists between stapedectomy or a stapedectomy. So essentially, are you going to remove the entire foot plate and cover the oval window with a vein graft with an overlying piston? Or are you going to make a small fenestration in the foot plate to accommodate the piston? The general trend is away from partial or total stapedectomy techniques for the following benefits cited in the literature. Theoretically, stapedectomy may cause less labyrinthine trauma, which would explain better high-frequency gains in the long and short terms, a lower incidence of sensory neural impairment, lower rates of perilymphatic fistulae, lateralization of grafts, and revision surgery. In terms of stapedectomy, the only possible benefit cited in the literature is some studies showing marginally superior low-frequency gain. The only true possible indication for primary stapedectomy is perhaps with an unstable foot plate, such as in a fractured or floating foot plate. There are now multiple different approaches to Stapes surgery. Traditionally, it has been performed via the microscope, either using an end oral incision or by working transcanal, either holding the speculum in the non-dominant hand or using a special speculum holder. Rarely is a retroauricular approach required. With the increase in endoscopic ear surgery, there's been an increase in endoscopic Stapes surgery. Initial advantages cited included an improved 3D visualization of the Stapes, often without requiring an epitympanotomy. However, concerns against the endoscopic approach included loss of depth perception, loss of the two-handed technique, and concern regarding thermal injury from the scope. The debate has recently been put to rest in a 2019 systematic review and meta-analysis, which showed no difference in terms of audiological outcomes, dizziness, tympanic membrane or chorda tympani injury, operative times, or post-operative pain. Conventionally, stapedectomy is performed by sequential dislocation of the incudostapedial joint, cutting the Stapes tendon and removal of the Stapes superstructure, followed by fenestration. Professor Fish introduced the concept of the reverse stapedectomy, where following adequate exposure, often requiring a superior canaloplasty, the fenestration of the foot plate and insertion of the prosthesis is performed prior to dislocation of the incudostapedial joint and removal of the Stapes superstructure. The theory here is that maintenance of the structural stability at the time of fenestration reduces the rate of incudal subluxation, as well as a floating foot plate. Audiologically, outcomes of the two techniques are comparable. However, reversal may not always be possible, such as in cases with limited access or a narrow oval window niche. or in cases of an obliterated footplate. Another decision which was again introduced by Professor Fish is whether one is going to perform a standard incus stapedectomy where the prosthesis is crimped to the long process of the incus, or a malleostapedectomy where the incus and head of the malleus are removed and the prosthesis is crimped to the handle of the malleus. The incidence of additional malleal fixation in primary surgery is found to be less than 6%, with a higher rate of up to 37% in revision stapes surgery. The decision is made essentially intraoperatively following adequate exposure, including visualization of the anterior malleal ligament, inclusomalleolar joint, the stapes footplate, the pyramidal process, and the tympanic segment of the facial nerve, as indicated in the top image. The ossicles are palpated, and if the malleus and incus is fixed, one should proceed to a malleostapedectomy. If they are mobile and fixation is at the stapes only, one should proceed to an incudostapedectomy. We therefore consider it mandatory to counsel all patients preoperatively on the possibility of a malleostapedectomy at primary surgery, as it's been shown to be associated with inferior audiological outcomes and a slightly higher rate of dead ear at approximately 3%. Just to run through some of the intraoperative challenges and complications described. Firstly, in the event of dual pathology where there's possibly a degree of canal stenosis or comorbid exostoses, as we mentioned earlier, exposure is key. The stapedectomy can be performed in conjunction with a canalplasty. However, where extensive occlusive disease exists, it may be better to stage surgery. The rate of post-operative tympanic membrane perforation is approximately 2%. And if injury to the tympanic membrane occurs at the time of surgery, one may continue with stapedectomy and repair with the cartridge or temporalis fascia graft. It's just important to remember to not reinforce with gel foam, which may displace your prosthesis. Injury to the chorda tympani can occur in up to 30% due to stretching and mobilization of the nerve, and very rarely sectioning it. It can be avoided by leaving the nerve attached to the reflective tympanic membrane. Most patients will actually not mention it unless it's inquired about or brought to their attention. Patients typically complain of a temporary dry mouth or metallic taste, and generally, if the nerve is not sectioned, it resolves after 3 to 4 months. In some cases, the facial nerve may overhang the stapes footplate. Generally, it's not an indication for abandoning surgery. However, one should avoid the use of a laser, which may cause thermal injury to the nerve. Some have described using the 0-degree endoscope or even a 30-degree endoscope to improve visualization and work around a corner. And if necessary, the nerve may be gently displaced at the time of fenestration and piston insertion. Reportedly, having the piston in contact with the facial nerve does not cause problems in terms of facial nerve function or audiological outcome. Overall, facial nerve injury is very rare. It may occur in the immediate post-operative period secondary to local anesthetic, or sometimes as a delayed temporary facial nerve palsy, which is described in less than 0.5% of cases, with recovery typically occurring over the following few days to weeks. Ossicular dislocations may rarely be found prior to surgery. Typically, subluxation of the incus occurs with incorrect curettage technique. It can occur with separation of the incudostapedial joint as well. As mentioned earlier, the rate can possibly be reduced by adopting the reverse technique. And if significant incudus subluxation occurs, one may have to convert to a malleostapedectomy, and again emphasizing the importance of consenting the patients for both procedures. The persistent stapedial artery is a rare congenital anomaly which may make stapedectomy challenging by obscuring the footplate or through troublesome bleeding. It's a remnant of the second branchial arch and a branch of the internal carotid artery. Its course is highly variable and may run between crura. A clue on the preoperative CT scan may be the absence of an ipsilateral foramen spinosum. Despite the added technical challenge, it's rarely a cause to abandon stapedectomy. It usually is described to occupy the anterior half of the footplate, in which cases a posterior fenestration can be performed. Alternatively, small arteries can be divided or space can be created by drilling out the oval window. Occasionally, access to the footplate is hampered by a narrow oval window niche. Here, an 8mm diamond burr can be used to create space. However, this does carry a small risk of acoustic trauma. Round window or obliterative otosclerosis usually is associated with a preoperative sensory neural hearing loss and is typically evident on a preoperative CT scan. It's due to obstructive otosclerotic foci at the round window and should be routinely inspected for following elevation of the tympanomeatal flap. If only partial, one can proceed with the Stapedectomy, but if the round window niche is completely obliterated, the procedure should be abandoned, as drill out of the round window is associated with an unacceptably high rate of sensory neural hearing loss. The biscuit footplate, as depicted in the top illustration, occurs in 3 to 11%. It's where you have this thick so-called rice grain footplate, which is at increased risk of causing a floating footplate. Theoretically, a skeeter drill is the ideal tool for fenestration in such a situation. A floating footplate occurs in less than 1%. Here, the footplate is avulsed from the underlying annular ligament and oval window prior to fenestration, with a subsequent risk of medial displacement into the vestibule if one proceeds. The rate of floating footplate can reduce again through adopting the reverse technique, through a meticulous sclerotomy technique, or possibly with the use of laser. Once it has occurred, management options include proceeding with the Stapedectomy, using a laser, proceeding with a total Stapedectomy, or postponing the surgery for 1 year and allowing refixation of the footplate. A fractured footplate may be managed using a 0.2mm elevator or pick to elevate the fractured fragments and proceed with a Stapedectomy or Stapedectomy. The Perilymph Gush is a rare intraoperative complication where following fenestration there's an uncontrolled excessive gush of perilymph and CSF. The main concern here is that it carries an increased risk of sensory neural hearing loss. As I mentioned earlier, it can be anticipated radiologically on CT scan in patients with a widened IAM or enlarged vestibular aqueduct, or controversially a dilated cochlear aqueduct. It's more common in association with congenital footplate fixation, and one should also be concerned in males of a risk of X-linked Stapes Gusher syndrome. In terms of management, control is best achieved by elevating the head of the table and continuing to gently suction the perilymph until the reservoir is exhausted. Mannitol can further be given, and generally one can proceed with Stapedectomy following this maneuver with a reinforced fat plug. However, occasionally the procedure has to be abandoned with fat or another connective tissue sealant used to plug the fenestration. Elevation of the head of the bed is continued post-operatively and may rarely be supplemented in severe cases with a lumbar drain. If we move on to some of the post-operative complications, sensory neural hearing loss can be immediate or delayed. The extent is also variable, with the rate of dead ear being reported at around 1% in primary surgeries and up to 4% in revision cases. Causes of persistent or worsening conductive hearing loss are elaborated on shortly. And tinnitus is common preoperatively and is generally improved by surgery, with the following study illustrating a 44% rate of cure, 34% rate of partial improvement, 16% remained unchanged, and 5% worsened following surgery, with a less than 7% development of new onset post-surgical tinnitus. A reparative granuloma is a rare complication, and it describes the formation of reactive granulation tissue around the oval window. And some literature has attributed it to particulate foreign matter from the prosthesis, or possibly from the surgeon's gloves or even gel foam, but this hypothesis remains unproven. The granuloma typically develops approximately 1 week after surgery, and patients complain of diminished hearing and dizziness. Otoscopy may reveal a granulation tissue in the upper posterior quadrant, and some authors have advocated systemic therapy with high-dose steroids and antibiotics. Inevitably, however, most cases require surgical intervention with careful removal of the granuloma and possibly delayed revision stapedectomy. A perilymphatic fistula can be primary and present in the immediate perioperative period or secondary, occurring in months post-surgery. It's more common with stapedectomy and revision surgery. Fistulas develop when there's a persistent or delayed leak of perilymph around the prosthesis or following displacement of the prosthesis. Numerous studies have shown that the use of gel foam as a sealant is associated with an increased risk. So again, connective tissue seals are preferable. Usually patients present with fluctuating hearing loss, which is mixed, tinnitus, vertigo, and 2/3 may have a positive fistula test on pneumatic otoscopy. And rarely patients may present with meningitis as a complication. Pneumolabyrinth is sometimes described on CT scan as depicted in the top right image. And generally the management is revision surgery. Meningitis, as I mentioned, is a rare complication. As we know, cholesteatoma can complicate any middle ear surgery, with some reports of cholesteatoma deposits at the oval window following stapedectomy. The risk of requiring revision surgery is most commonly quoted as 20% over a 20-year period, and most of the literature has quoted inferior audiological outcomes compared to primary surgery. In a prospective study by Professor Vincent of 652 revision cases, the following surgical findings and reasons reported for failure were found, with erosion of the long process of the incus by far the most common, followed by an inadequate length prosthesis and incomplete primary surgery. So the next challenge is what to do in the situation such as depicted in the audiogram below. The previous audiogram is an example of what is being termed as far advanced otosclerosis, which describes a patient with otosclerosis with average air conduction thresholds of over 85 decibels and bone conduction which is unmeasurable due to the limits of audiometric equipment. I think we can all agree that these patients are beyond the help of a conventional hearing aid alone, and 3 possible management options are described: stapedectomy with subsequent fitment of a conventional hearing aid, cochlear implantation, and the newer direct acoustic cochlear stimulation device. Where considering the first option, one wants to try and exclude a purely sensory neural hearing loss, which would obviously not be amenable to stapedectomy and hearing aid. Features suggestive of a conductive component are suggested by a shorter history of disease, a positive family history, previous audiogram showing an air bone gap, preservation of speech and word recognition scores, and an absence of cochlear otosclerosis on CT scan. In such patients, stapedectomy will raise the air conduction thresholds to levels at which the patient may benefit from a hearing aid. Advantages of this strategy include that it is comparatively less expensive, less invasive. It can routinely be performed under local anesthesia with a lower auditory rehabilitation requirement, and cochlear implant can always be reserved as a backup. In terms of cochlear implants, otosclerosis accounts for 10% of implants in adult cochlear implantation programs in the UK. Cochlear implants may be an option for patients with advanced bilateral disease due to disease progression or complications of surgery, for patients meeting the usual audiological criteria for CI with severe to profound bilateral sensory neural hearing loss, and in patients where other amplification methods have been unsuccessful, including stapedectomy. It's important to mention that salvage CI following a failed stapedectomy has comparative outcomes to patients who did not previously have stapedectomy with so-called virgin surgical ears. Problems specific to CI and otosclerosis include difficulty with insertion of electrodes due to otosclerotic foci, soft otospongiotic bone, and possible obliteration of the round window. Challenging post-surgical changes may be found following previous stapedectomy or other Stapes surgery. An increase in the rate of aberrant facial nerve stimulation may occur due to transmission of current via otosclerotic foci, and is said to occur in up to 38% of cases. This can sometimes be overcome by deactivating electrodes in the vicinity of the geniculate ganglion. Despite these challenges, the CI in postlingually deaf adults with otosclerosis has been shown in multiple studies to have equivalent outcomes in terms of audiological parameters and quality of life measures when compared to implanted non-otosclerotic patients. The third and final and newest option is the direct acoustic cochlear implant manufactured by Codex. The device, as illustrated in the picture, essentially consists of an external processor which provides amplification and signal processing, which is transmitted via an actuator to an artificial incus transducer or type of middle ear implant, onto which a conventional Stapes piston is crimped and inserted into a fenestrated footplate. Acoustic stimulation is then directly transferred to the cochlear perilymph, and this is in contrast to a cochlear implant, which stimulates the cochlea electrically via the electrode. There's a significant overlap in terms of indications with CIs, both being indicated in cases of severe to profound hearing loss. Both options also having comparable outputs in excess of 125 decibels. So far, early research suggests that patients with adequate cochlear reserve with bone conduction thresholds less than 60 decibels have better results with this modality in terms of speech perception and hearing and noise. Other benefits include faster and less intensive auditory rehabilitation, and it further does not negate a future cochlear implant. As far as I can tell, these units are currently only available in some parts of Europe and limited to clinical trials. So in interest of time, I'll end there. Thank you very much for listening to me today. These are a list of some of my references. And again, thank you very much.
Thanks, Matt, for that excellent presentation and comprehensive overview of the subject. In the interest of time, we only really have time for a few questions. Are there any questions from the audience? If there are no questions, perhaps we could just ask some of our experienced colleagues just for some discussion points and input. Maybe we can just start with Dr. Kenneth Baidu from Ghana, whether, just to talk about their experience of otosclerosis, whether they see a lot, and essentially how they manage the patients, the workup and surgical approach.
Well, thank you very much. We don't see a lot. I don't think the recent years I've seen anybody suspected with otosclerosis. So I don't have much to talk about otosclerosis.
Thanks, Dr. Baidu.
Hello?
Thanks.
Right.
Thanks. Could we ask Dr. Michael Medina of his experience in the Philippines, whether they see otosclerosis and perhaps the surgical approaches used there? Okay. Perhaps we'll get back to him. In South Africa, we could just ask perhaps Prof. Sedat from the Free State for any comments.
I think it was an excellent presentation, Matthew, very comprehensive. We do see it in black patients. I think it's probably underestimated in black patients. It's not as common as we'd like it to be for training purposes.
Thanks, Prof. Lastly, we could just hear from Dr. Feroz Essa in KZN, whether you've got any comments, particularly on workup and perhaps surgical approach.
Yeah, good morning. I think it's an excellent presentation. I must say it's been a challenge training for autosclerosis. So I was at UCT and we did not see that many cases. So it is a challenge. However, in recent years, with the advances in endoscopic work, it makes the appreciation of the anatomy much better than what you would see with the microscope. You can get into these nooks and crannies. And started using the endoscope about 4 years ago. And I found that to be a better tool to use when doing endoscopic stapedectomies, or staphydoctomies rather. The comment on the gel phone is, I think, super important. And just one other nuance, when you're using fat to plug in, you have to be careful how much of fat you're using. And if you use too much of fat, you're going to end up with a lot of fibrosis. And if you have to go back in, you're going to find a lot of stranding at the base of the prosthesis. That's all I have to say.
Thanks. Now I'm going to just hand over to Dr. Harris, who's our otologist and lateral skull-based surgeon here at UCT, just to give some commentary.
Thanks, Nick. That was a very excellent presentation, Matt. So we don't do that many. We probably do about 50 a year at Autosclerosis, and I think the main reason is that hearing aids are quite expensive. So I think in our population group, a lot of people are opting for surgery, probably because they can't afford a hearing aid more than any other reason. I must say this is the one type of surgery that for me is all or nothing. And I still consider myself one of those people that are still very much on that learning curve. I definitely haven't plateaued. I haven't seen every complication in the book. I haven't seen reparative granuloma. I think I've seen one gusher in the past couple of years that I've been doing a safety surgery. But I think for me, the most important thing here is really the consent. And that when patients actually sign that piece of paper, to remember that this is really quality of life surgery, it's not life-saving. And you have to be, the patient has to be absolutely sure that they are prepared for every possible consequence or complication. You know, that has to be very clear in their mind, because the other option is still very much a hearing aid that will work well in most patients. So I think it's really important to the consent process for me is really the biggest part of this, and that patients understand what they're signing up for. But it's very satisfying surgery because one has the ability to almost immediately have the patient benefit from the surgery. So it really is very satisfying surgery, but well done, Matt.
Thanks, Dr. Harris. If there are no further questions, we're about to close the meeting. If you would like to view the presentations, they are recorded. If you just like to subscribe to our YouTube channel, you can just type in UCT-Africa Virtual ENT, and all the presentations are uploaded online. A reminder, if you would like to participate on this open platform and to present, you can email myself or Tasia Din, and we'll get back to you. Our next presentation is this Friday at 8:30, and it is our academic ward round and case presentation. So we invite everyone to join and to spread the word. Thanks a lot. I'm going to end the meeting.